On behalf of Indian Society of Hematology and Blood Transfusion, I invite all the delegates for today's meeting. For the no wasting time, I would like to invite speaker for today's meeting, Dr. Ganesh Jashetwar. He is a lead consultant and head Department of Hematology and BMT Yashoda Hospital, Somaji Guda, Hyderabad. Over to you, sir.
Thank you so much. Good evening, everyone. At the outset, I thank one and all for joining amidst the busy, hectic schedule on a weekday. All my seniors, colleagues, my teachers, and students. So the topic of today's presentation is basics of stem cell transplant. So thank you so much. So at the outset, I would like to thank the organizers and the organizing committee of such fantastic, wonderful masterclass periodically. The entire ISHBT team, notably all my teachers, Dr. Maitri Madam, Dr. Prantar Chakravarti sir, Dr. Utpal Chaudhary sir, Dr. Tufan Dole sir, and all the seniors teachers from ISHBT group. So I had no conflict of interest for this presentation today, and the outline of my talk is going to be, I'm going to discuss the basics of bone marrow transplant. So essentially, what is a hematopoietic stem cell transplant to be precisely, the bone marrow transplant, and how do we get here today? I'm going to dig out little in the history because unless and until we go back into the past, we don't realize what we have, and we don't get an idea how to achieve further milestones beyond what we have achieved till now. Who needs bone marrow transplant? So basically indications of bone marrow transplant and the bone marrow transplant as a procedure in brief summary, and where the future of hematopoietic stem cell transplant or bone marrow transplant going to lead us to, and why we need to update ourselves in this field with regard to newer developments and the current science. And this is relevant not only to the hematologists and bone marrow transplanters, but to the entire medical fraternity, whether you are coming from a medicine group, you are a physician, a pediatrician, or a general practitioner, because bone marrow transplant is a teamwork with everyone. The process of bone marrow transplant is a miniature part of the entire journey of the patient undergoing transplant. Subsequently, post-transplant follow-up, the responsibility lies on all the clinicians in the community practice, and who are the major pillars determining the success and the survival of these patients once these patients are released from the hematologist or bone marrow transplant into the community. So essentially, hematopoietic stem cell transplantation is a unique procedure which is known to cure cancer, various immune disorders, bone marrow failure syndromes, bone marrow aplastic anemia, and various metabolic disorders. So contrary to our belief, it is not a surgery. It is a simple stem cell infusion wherein you utilize healthy hematopoietic stem cells from a HLA matched donor, and the source of these stem cells can be from the donor's bone marrow or from the peripheral blood mobilization on an apheresis machine or a cord blood. And these hematopoietic stem cells, after being into this patient's body after a conditioning chemotherapy, which eradicates the diseased bone marrow, and these healthy stem cells regenerate, repopulate, and regenerate the entire hematopoietic system, which is of donor origin, and which gives the lifelong hematopoietic recovery as well as immune recovery, which is of donor origin in these patients. So there had been this procedure is existent, this bone marrow transplant or hematopoietic stem cell transplant, as a curative therapeutic option across vast hematological disorders, not only blood cancers, has been existent over more than 65 years since the first successful hematopoietic human stem cell transplant in 1956, and till date there have been more than 10 lakh patients who have been benefited with this bone marrow transplant procedure. So it is fascinating to just understand how these hematopoietic stem cells, which are rare cells in the bone marrow, and then they are so powerful, they can generate the entire gamut of hematopoietic system in the patient or the recipient, and this regenerative potential can be used for the cure of vast majority of hematological conditions, not only blood cancers and pediatric solid tumors, but a number of non-malignant conditions. The indications of bone marrow transplant are ever expanding. To name a few are like bone marrow failure disorders or syndromes, genetic disorders, hemoglobinopathies like sickle cell anemia, thalassemia, immunodeficiency disorders, so on and so forth. An upcoming role of autologous transplant in suboptimally managed severe autoimmune conditions. So before I start the journey of bone marrow transplant, I'll kickstart with a case. And this is a 9-year girl, which I had seen in 2016. She's a class 4 student. She presents with severe symptomatic pancytopenia with fever, bleeding, and severe anemia. And to add to the nightmare, she was shifted from another hospital, and her blood culture in the previous hospital had grown MDR, that is multi-drug resistant E. coli, sensitive only to colistin. So it was resistant to third generation cephalosporins and carbapenems. So this was her presentation in December 2016, fatigue, respiratory tract infection, bleeding, and this was her hemogram picture, severe pancytopenia. You can see from the hemogram picture here, hemoglobin is just 6, WBC 300, platelets 10,000. And on the peripheral smear, you can see a just empty peripheral smear, occasional lymphocytes and very scarce red blood cells, and literally no platelets on the peripheral smear. So we did the bone marrow. It was a completely empty marrow, completely replaced with fatty globules. The cytogenetics was normal. The stress cytogenetics was reported negative. So we do stress cytogenetics to rule out inherited marrow failure syndromes in younger patients like this girl. So this is her picture, and you can see so the diagnosis is very severe aplastic anemia, in fact, because her absolute neutrophil count is less than 200. So how to treat such a patient who had a very severe aplastic anemia? And you can see on the culture plate E. coli, and that is resistant to all the antibiotics. You can see the only 12 o'clock position antibiotic, that is colistin, is showing a peripheral rim clearing, and that means that the only antibiotic sensitive to this bug is colistin, and this E. coli is resistant to all the carbapenems and cephalosporins. So this is an emergency condition. So we stabilized this girl with transfusions, including granulocyte or white blood cell transfusions, to fight the multi-drug resistant gram-negative sepsis. And we did the workup for bone marrow, subsequent bone marrow transplant. She was the single daughter of the family. So we did HLA typing and anti-HLA antibody from both the parents, and both the parents, as expected, are HLA half match or haploidentical to the girl. So we did first emergency half match transplant with this kind of conditioning, which is for aplastic anemia. We use immunosuppressive conditioning chemotherapy. So the chemotherapy conditioning used was fludarabine, cyclophosphamide, and rabbit ATG, and a 2 gray of TBI to intensify immunosuppression, because the rejections are high in any HLA mismatch transplant. So the donor was father. Unfortunately, you can see 35 days post-transplant, she's severely pancytopenic. We did all the workup for persistent pancytopenia, including infections, drugs. We did bone marrow, it was empty. We did XY chimerism, because the father is the donor and the girl is a female child. So the XY chimerism, which comes quickly in a matter of just 3 days, the XY chimerism showed 100% XX cells. That means the girl has rejected father stem cell graft. So in any HLA mismatch bone marrow transplant, one of the major challenges is graft rejection, and the risk can be as high as 10 to 30%. So median of 10%. So this girl unfortunately has rejected her graft. Now, mind you, she has multi-drug resistant E. coli sepsis, and she is profoundly pancytopenic for a period of close to 5 weeks. So the only way to save this girl was to take her for another consecutive second haploidentical transplant, and this time we switched the donor to mother. We escalated the dose of rabbit ATG to the mega dose of rabbit ATG, 10 milligram per kg. We gave fludarabine 160 milligram per kg. We increased the dose of TBI to 4 gray from previous 2 gray. So in this way, we intensified the immunosuppression to ensure the chances of engraftment in second transplant. And you can see 1 month post transplant, she has nicely engrafted. The second transplant was successful. She was neutropenic close to 78 days. And you can see the transplant was successful in March 2017, and then continuous follow-up. The counts were normal. She has, of course, post-transplant usual complications, more so in a double half-match transplant. She had CMV reactivation, which is peculiarly common in alternative donor transplant. She has manageable grade 2 skin and gut acute GVHD, which was managed with steroids and targeted drugs, ruxolitinib. So she continues to have chronic manageable skin and mouth GVHD, and the last follow-up was recently December 2022, and this was her recent picture. So she's now turned into a 16 years beautiful looking adolescent who has her menses since last 2 years. So again, this is a exceptional case. Don't take the message that this kind of cases are common. So I just wanted to highlight the care and the immediate decisions and the the scientific follow-up of all the protocols can lead to such successes. So this was definitely a natu moment for any transplanter undertaking such challenging cases. So with that, we'll just peep into the brief history of bone marrow transplant, how it had evolved over last 7 decades. We will then discuss the present bone marrow transplant issues. What are the the logistics of bone marrow transplant? How do we manage it? The early complications, the late complications we should be aware of. Both the hematologist as well as the community practitioners, because this is a teamwork. The patient is going to get back to the their native places, and where the patient has to follow up with the primary care clinician in collaboration with the hematologist and bone marrow transplanter. And what is the future of bone marrow transplant? Where the future is leading us to, and what are the possible newer breakthroughs in the field of bone marrow transplant. So the part 1 is history. So I'm going to take you through brief pages of history because I found it very, very interesting. And digging deep into the history can give you a better perspective of what we have and what we can aim and achieve in the future in the field of hematopoietic stem cell transplant or bone marrow transplant. So we need to look back to move forward in a better and in an optimal way. So the bone marrow transplant as a specialty, the technique and the procedure took off after the 1940s atomic bombs happening in Hiroshima and Nagasaki, Japan, which precipitated immense research in the field leading to bone marrow transplant. So you can see the earlier reports, 1950s growth and continued function of rat marrow cells in lethally irradiated mice, again by Peter Nowell from the US Naval Radiological Defense Lab. So, and again, another paper in 1956 published in Nature, Cytological Identification of Radiation Chimeras. So initial work in the field of hematopoietic stem cell transplant was done across the US defense as well as US atomic energy research establishments because of the valid reasons. So the initial breakthrough for the experimental stem cell transplant came through the Jacobson's radiation protection experiments, wherein he either injected the splenic cells from a healthy mouse to lethally irradiated mouse, or he also tried shielding the hind limb, wherein the bone marrow stem cells were protected. And these the mouses who were injected with spleen cells and whose hind limb was shielded were protected, and they survived this lethal irradiation. And initially it was thought that it was a humoral factor which lead to hematopoietic recovery post such lethal radiation, but It was Ford's experiments who proved that it was not a humoral factor, but it was the splenic cells, the possible potentially hematopoietic stem cells, which have repopulated, regenerated the hematopoietic system and rescuing these lethally irradiated mice. So this was the Ford's experiment. So again, with those mouse experiments, parallelly, the team led by Professor Donald Thomas, initially at Cooperstown, New York, at Harvard Medical School, they have first published their paper in NEGM 1957, wherein they tried the terminally ill advanced blood cancer patients. 6 of these patients were tried to be treated with lethal irradiation to control or to destroy their terminal blood cancer, and then were rescued with hematopoietic stem cells. But none of them survived, and out of 6, only one had transient hematopoiesis, and all of them died before day 100 post transplant. But this was the first attempt. So the logic and the rationale Dr. Donald Thomas and his group put forward, because since the cases of radiation disaster may occur, and since bone marrow deficiency from radiation and chemotherapy does occur in the normal course of clinical medicine, an effort has been made to determine the availability as well as usefulness of these bone marrow infusions for the treatment of such dying patients. And as a surprisingly and interestingly, NGM has such a funny editorial. You can see on the paper that in an atomic age with the reactor accidents and not to mention stupidities with bombs, somebody is going to get more radiation that is good for him. If infusion of marrow can induce recovery in a mouse or monkey after lethal radiation, one had to be prepared with this form of treatment in man. And mostly the leukemic patient who needs radiation and bone marrow, as well as uremic patient who needs a spare kidney, these are the patients who need the rescue stem cells or rescue kidney to protect them from the organ failure. So these are the people who deserve immediate consideration. So from helping them, one will be preparing for the atomic disaster of tomorrow, and it is high time we did. So it was interesting editorial in NEGM published way back in 1957. I'm sure nowadays we don't get such funny editorials anymore in any of the journals. So because of these dismal outcomes initially, the number of experimental human bone marrow transplant rapidly declined. You can see 1958 to 1962, the stem cell transplant, you can see significant number of patients were tried for hematopoietic or stem cell transplant or bone marrow transplant. But because of the dismal outcomes, you can see 1964 onward, the number drastically decreased. And then subsequently, Professor Donald Thomas moved to Fred Hutch Cancer Research Center at Seattle, and he started experimenting in dogs. So you can see this is one of the press meet where all these dogs who were transplanted from their littermates stem cells, and they survived for a significant period of time. So the first dog, the Donna, who survived 4.5 times lethal radiation and was possibly cured because she survived 12 years. So normal dog's lifespan is 10 to 15 years. So she survived for 12 years. So possibly, even though that time the HLA typing, even serological, was not yet discovered. So possibly by accident, by chance, she must have been transfused with a HLA match sibling or syngenic sibling from her canine family. So again, this was a interesting newspaper article, Nobel Prize for this test dog, because this was the first literature documented evidence of any animal being cured with successful bone marrow transplant. So the bone marrow transplant, the Hall of Fame. So initial, as I discussed, the radiated mice being protected with spleen cells. This was Jacobson's experiments. And then 1957, the NEGM paper, the first human bone marrow transplant, even though not successful, but that established the concept. Subsequently, 1958, Professor Dr. Jean Dosset was the first one to discover HLA-A antigen. And then in 1960, with the nuclear accident in Yugoslavia, 6 patients from that lethal nuclear exposure were taken for bone marrow transplant by Professor Georges Mathé in Paris, France. And out of those 6, 5 survived, even though HLA serological typing was not available or not discovered till that time. The theorem or the rationale proposed is that possibly all these patients have received sublethal dose and they have autologous stem cell recovery, but this is an important milestone. So subsequently, in the same year, Medawar, the father of modern immunology, has groundbreaking work in the field of transplant immunology, which led to the successful establishment of kidney transplant in North America as well as in Europe. So subsequently, the first literature documented evidence of human hematopoietic stem cell transplant was in 1963 by Robert Cayley at Mayo Clinic, Rochester. So essentially, during that time in 1960s, Dr. Demshek sent 2 of his students, which included Dr. Robert Cayley, for 1 week training at Cooperstown under Dr. Donald Thomas. And Dr. Robert Cayley, after having the first-hand exposure to the experimental bone marrow transplants, came back. And 3 years later, in 1963, he came to see one girl, Nancy King, who was 10-year-old, very severe aplastic anemia. And mind you, that time, the treatment for aplastic anemia was pulse steroids, and you can see because of the pulse steroids, Nancy has such Cushingite features. So one of the interesting observations of Dr. Cayley, Nancy used to be accompanied by her sister Bonnie, and the only way that they are compatible with each other with regard to their genotype so was the skin grafting. So the skin graft from Nancy and Bonnie's legs were transplanted in each other respectively, and since the skin graft survived, it was assumed that they are HLA matched or they are genotypically matched. Even HLA nomenclature was not yet established that time. And then Nancy was transplanted with the HLA matched syngeneic stem cells from her sister, and almost more than 6 decades of this first syngeneic hematopoietic stem cell transplant for very severe aplastic anemia, Nancy continues to enjoy a good life, and she's completely healthy and normal. This was her recent picture. So subsequently, in 1968, John Van Roode and Paul Terasaki described the model HLA typing, and in the same year at Memorial Sloan Kettering Cancer Center, Dr. Robert Good, the famous immunologist, did first HLA matched sibling donor transplant for a 2-year boy, David, who was suffering with SCID, and all the 11 male child in his maternal side has died, succumbed to such immunodeficiency. David has 3 sisters, and one of his younger sister was found to be HLA identical with him. So David got HLA match sibling donor transplant from his younger sister, and David is cured, and he lived more than 50 years post this first successful allogenic stem cell transplant. Subsequently, in 1971, Donald Thomas published his series of hundreds terminal blood cancer patients who were transplanted with their HLA matched siblings, out of which only 18 patients had a long-term survival. It's fascinating that during that time, the long-term survival out of 100 was 18%, but still it was meaningful because these patients have no hope beyond this. And the landmark paper was published in 1917 in NEJM and 1971 in NEJM, and Donald Thomas subsequently in 1995 was felicitated with Nobel for his groundbreaking work in the field of hematopoietic stem cell transplant. All these 100 patients, again, an interesting fact, they were treated with radiation-based conditioning. So, in the Department of Atomic Energy Commission, in the bunkers, these patients were taken for radiation, quickly shifted to the ward and taken for such a Herculean hematopoietic stem cell transplant or bone marrow transplant that time. And this was the landmark paper published in NEJM in 1971. So again, in the first unrelated donor transplant happened in 1973. Again, by this time, HLA typing was serological. The primitive HLA typing was available widely. The unrelated donor transplant happened 5 years of first HLA match sibling donor transplant in 1968. So by this time, even though there was no HLA donor registries across the globe, but one of the patients, Simon Bostick, who was 2-year-old and who has chronic granulomatous disease, Simon Bostick's mother has a interview in British Broadcasting Group, and that interview went quite viral. You can imagine, without mass communication media at that time, newspapers and radio, the message went viral, and it was urged for the donors to come forward and get HLA testing done to find a match for Simon Bostick. One of the donors from UK was found to be matched, HLA matched with Simon Bostick, and Simon Bostick underwent first unrelated donor transplant at Westminster Children's Hospital, UK, under the team led by Dr. John Hobbs. And this is Simon Bostick's recent picture, completely cured, and more than 55 years post-transplant, leading a normal life. So this was the first documented evidence of unrelated donor transplant in the bone marrow transplant history. Motivated by this fact, again, Shirley Nolan, her son, 1.5 years, Anthony Nolan, who has very severe Viscott-Aldrich syndrome. Unfortunately, he succumbed, but motivated by this news of Simon Bostick, Shirley Nolan moved to UK, and she was the founder of the first international unrelated donor stem cell registry, Anthony Nolan, in UK. So in 1983, again, another milestone come. Till 1983, all the bone marrow transplant conditionings were TBI based. So Josh Santos from John Hopkins Group first described non-TBI based conditioning with busulfan, initially cyclophosphamide and then busulfan. And in the same year, first autologous stem cell transplant for relapsed non-Hodgkin's lymphoma was done in David Vetter. So he is also post-successful autologous stem cell transplant. He survived for more than 4 decades. And then subsequently, 1988, first umbilical cord blood stem cell transplant happened by the groundbreaking work of Dr. Broxemeyer, who has an immense interest in umbilical cord blood stem cells. He worked more than 10 years on that. And the first umbilical cord blood transplant was done by Dr. Ellen Gluckman at Hospital St. Louis in Paris, London, on a child, Matthew Farrow, suffering with Fanconi's anemia. So his younger sister, who was not yet born, so his mother traveled all the way from North Carolina to Paris, France, and where at the birth of his sister Alison, the umbilical cord blood stem cells were collected, and Matthew Farrow underwent first umbilical cord blood transplant. And Matthew Farrow still continues to enjoy a healthy, normal life, and he works as a volunteer to generate and to create awareness about umbilical cord blood stem cells across Europe and North America. So again, 1996, the first conceptual wavefront of reduced intensity conditioning, because till now all the myeloablative conditioning was used, which was used only for the fit. Younger patients, old patients, or patients with comorbidities were not eligible for bone marrow transplant. So with the groundbreaking work of Dr. Shimon Slavin from Israel, Dr. Sergio Giralt from MD Anderson Cancer Center, and Dr. Reynolds from Fred Hurst Cancer Research Center, Seattle, all these 3 groups together had groundbreaking work in reduced intensity conditioning. And after this, 1996, many the older patients and patients with comorbidities were taken for transplant and were becoming eligible for transplant. Subsequently, again, reduced toxicity conditioning concept harbored and nurtured by 3 groups, again, Dr. Martin Bornharzer, Dr. Claudia Anasetti, and Dr. Joachim Dick. And subsequently, the first breakthrough in the field of haploidentical transplant happened in 2008 from John Hopkins group, led by Dr. Leo Luznik and his researcher Ephraim Fuchs, who first described post-transplant cyclophosphamide platform for haploidentical transplant with very promising results. So that changed the way we do haploidentical stem cell transplant nowadays. And subsequently, in 2011, the pediatric hematologist Dr. Enida Nemec from Oregon Health University discovered the first reduced toxicity conditioning drug, tiosulfan. So again, 2010 was a landmark year for T-deplete haploidentical stem cell transplant. Initially, by the phenomenal work by Rupert Hangrettinger from Germany, and then subsequently Dr. Martimo Martelli and Franco Aversa from Perugia Group, Italy, and Dr. Alina Becce, along with her mentor, Franco Locatelli from Rome, Italy. So the initial and even today, a lot of T-deplete haploidentical stem cell transplant, the credit goes to these phenomenal researchers. So that was brief about history. Now the part 2 of my talk. So what is the logic of transplant and what are the indications of transplant? So the aim of transplant or the aim of bone marrow transplant for malignant conditions is to permit high dose chemotherapy so that the maximum cancer kill can be achieved as per the Gompertz law. And at the same time, the donor-derived hematopoietic stem cells, they continue to attack the host cancer cells, and that effect is called as graft versus leukemia effect. And by this graft versus leukemia effect, the relapse risk is much lower in the transplant arm compared to non-transplant conventional chemotherapy arm. So that is the logic for malignant indications, whereas non-malignant indications to restore normal healthy hematopoiesis and to replace defective genes in the field in cases of genetic disorders, and that is the logic. So we definitely need to think differently when we consider the rationale of bone marrow transplant. So replacement of defective marrow stem cells with normal functioning cells from a healthy donor, for example, immunodeficiency disorders like SCID, where lymphocytes are defective. And the first SCID baby, David Vetter, who survived beyond first decade way back in 1970, and that was because of, you can see the bubble care. So, these are immunocompromised patients who succumb to various life-threatening infections. So David Vetter was from an affluent family, and his parent could afford this bubble care, sterile bubble care. You can see even for the play, he used to be taken in this bubble. And David survived up to 18 years because of such bubble care. So, in the modern bone marrow transplant, the concept is more or less same. When we take the patients for transplant, because of the profound cytopenia, we tend to take similar bubble care in a more advanced and a more modern fashion. So this was interesting, David Vetter and the bubble boy of that century. So again, in conditions like hemoglobinopathies like thalassemia, where erythroid cells are defective and these typical facies are because of expanded erythron, again the bone marrow transplant can be curative. And again, when myeloid cells are defective, like various diseases like Chediak-Higashi, chronic granulomatous disease, again a boy with Chediak-Higashi syndrome, you can see gray hairs, again bone marrow transplant is curative. And when all the three hematopoietic lineages are defective, like we have seen with our first case, again conditions like aplastic anemia or inherited marrow failure syndromes, the bone marrow transplant is curative. Now, the second logic of bone marrow transplant is to rescue the marrow from high dose chemo or chemoradiotherapy, and also to exert graft versus leukemia effect. So this is exploited for, this effect is exploited for various malignant indications like high risk AML, ALL in mostly in the relapse setting in pediatric group, CML in the blast phase, leukemia, lymphoma, autologous transplant. So these are the malignant indications. Again, pediatric relapse refractory neuroblastoma cases. These are the cases where you give high dose chemotherapy, and by doing that, the bone marrow is destroyed, and then you rescue the bone marrow with pre-collected hematopoietic stem cells. So the third logic is involve errors of metabolism, where the generalized gene defect. What happens here, the tissue damage is because of buildup of toxic metabolites. So by doing the transplant, these donor tissue histiocytes repopulate the affected organ, remove the toxic metabolites, and can even eliminate or reverse the organ damage. And also it can replace the defective genes and enzymes, thereby preventing the further organ damage. So this was the logic. So let us peep out again into the history, milestones in transplant, first world versus India. So as I mentioned earlier, 1956, Cooperstown, New York, first allogenic hematopoietic stem cell transplant by Donald Thomas. And then in the first allogenic stem cell transplant was happened in India at Tata Memorial Hospital, Mumbai, under the guidance of Dr. S.H. Advani, the father of oncology in India. So during 1980s, Dr. Advani and Dr. Gopal Ramakrishnan was sent by the government of India for training under Dr. Donald Thomas at Seattle. And after returning back from Seattle, Dr. Advani and his team, including Dr. Purna Kurukure, Dr. Tapan Saike, and Dr. Gopal Radhakrishnan, did their first transplant for a girl, Vandana Kadam, so a 9-year girl with AML, and the first transplant was done from her younger brother, 7.5 years, Umesh Kadam. And post this first allogenic stem cell transplant, Vandana Kadam survived for more than 22 years. And after 22 years, she succumbed not because of her disease, not because of her cancer, but she had severe pancreatitis and uncontrolled diabetes, and that was the reason for her fatality. Subsequently, the first after 1984, the first allogenic stem cell transplant for benign hematological condition like thalassemia was done by Professor Maman Chandia at Christian Medical College, Vellore, for this boy Satyanarayana. So again, the first unrelated donor transplant happened in Westminster Children's Hospital, done by Dr. John Hobbs in UK in 1973, whereas the first unrelated donor transplant took longer time to happen in India in 2006, again by the team led by Dr. Maman Chandia at CMC Vellore, for a young boy of AML who was transplanted with unrelated donor stem cells and who survived for many, many decades, who is still doing well post-transplant. So again, the first umbilical cord blood transplant happened in 1988 at Hospital St. Louis, Paris by Ellen Gluckman, whereas the first umbilical cord blood transplant happened in India, the family HLA match umbilical cord blood transplant 1996, again at Tata Memorial Hospital by Dr. Advani sir, Dr. Thakia sir and his team, whereas the subsequent extensive work in the field of umbilical cord blood transplant has been done by Dr. Revati Raj at Apollo Children's Cancer Center at Chennai. So Dr. Revati Raj has a huge number of umbilical cord blood transplants to her credit in India. So again, the first haploidentical transplant was happened in 1980 by Dr. Yaiser Rayner and Richard Rayleigh at MSKCC New York, whereas the first haploidentical transplant in India was done by Dr. Suparna Chakravarti in 2009 at Apollo Hospital at Kolkata. Whereas the first T deplete, so TCR alpha beta T depleted haploidentical stem cell transplant was done in 2010 by Dr. Rupert Handgren and Franco Locatelli, respectively, in Germany and Italy, whereas the first T deplete haploidentical stem cell transplant was done in India by Dr. Satyendra Kattev and Dr. Satya Yadav sir at Fortis Memorial Hospital, Delhi in 2014. So this was just brief about milestones. So again, on the same context, this is an interesting case. This I had seen this boy, young boy of CML blast crisis with T315I mutation in September 2015. So again, he was 22 years. He has T315I mutation. So I took him for 2 cycles of FLAG-IDA, with which he achieved MRD negative CR. But however, subsequently, when he was about to be geared up for haploidentical stem cell transplant with father as his donor, he presented with severe headache, and the CSF analysis showed 4,400 CNS B lymphoid cells. So it was a CNS B lymphocytic relapse. So again, salvaged with triple IT, 2 cycles of high dose methotrexate and whole brain RT, and subsequently he was taken up for TCR alpha beta CD19 deplete haploid identical stem cell transplant with father as a donor in February 2016. So almost close to 7 years post transplant, he still continues. 6 years post transplant, he continues to do well, healthy, free of his disease. So just the point here is not about these different transplants, but bone marrow disorders, blood cancers are not the end sentences, and the novel, newer techniques and newer therapeutic options like hematopoietic stem cell transplant can be curative in a significant number of patients. So changing gears further, so the part 3, the patient as well as donor selection. So how do we select patient? So basically there are various tools to define disease risk as well as the candidate who's evaluated for hematopoietic stem cell transplant. So the disease risk, there are various tools, comorbidity index and psychosocial assessment, very important. So these are various disease risks. So DRI, there are many smart calculators, medical smart calculators available. You just put the patient data and you come up with various scores, and based on the scores you can predict the survival parameters like overall survival, the relapse risk in these cases. Now coming to stem cell transplant associated comorbidity index, the most famous and popular is hematopoietic stem cell transplant comorbidity index. Again, you can see based on various organ dysfunctions, the score can vary, and based on these scores, you can devise the score. And how this device is important, you can see for patients having HCT-CI score more than 3, the non-relapse mortality, the toxicity risk is more than 40%. So, when the NRM exceeds 20%, you should try to defer the transplant or should think of alternatives. So again, the long-term survival you can see for HCT CI score more than 3 is less than 30%. So that's how you devise the patient, and you select the patient. So again, combining the disease risk as well as HCT CI score, you can see both put together refines the risk stratification of the patients undergoing hematopoietic stem cell transplant. Now coming to the donor choices for hematopoietic stem cell transplant, there are various parameters we think of. The most important is HLA compatibility, donor gender, parity, age, CMV status, ABO grouping, and special donor health issues. So this was the previous algorithm. The HLA identical sibling donor first preference. If not, then fully HLA match international unrelated donor. And if that is also not available, then used to search for either cord blood or single antigen or permissible mismatch unrelated donor, and the haplo was last in the donor search algorithm. But nowadays you can see why this is important, because each SLA mismatch has a significant impact on long-term outcomes. So there is almost 10 to 15% decrease in the long-term survival with each HLA mismatch. So donor choices, unfortunately, only 25% patients have fully HLA matched family sibling donors or family member who is fully HLA matched with them. Whereas for minor population like Southeast Asian countries, India, the possibility of finding unrelated full match donor is only 15 to 30%. But almost 40 to 75% patients were in dire need of transplant end up having no HLA matched donor, either family members or international donor registries are formed for them. These are the various choices, either mismatch unrelated donor, cord blood transplants, or haploidentical donors. Now, the important thing for donor selection is you try to, opt for the full match donor compared to full match family donor versus unrelated donor versus one antigen mismatch, and the haplo is the last. But again, mismatch locus preference, the DRB1 mismatch is the worst, followed by A, B, C in sequentially. So again, so haploidentical donors, there are many advantages. Of course, there are disadvantages, but there are novel advancements in the science and technology of transplant with which these haploidentical transplant results can be almost as good as unrelated full match international donor transplants, and in some select circumstances as good as match sibling donors in some conditions. So again, impact of ABO matching, you can see mismatch. There is some decrement in the long-term survival as per the CIBMTER data. So ABO status, there is no compelling evidence of role of ABO matching. However, if there are choices amongst multiple available donors, ABO match is preferable. So again, these are the various advantages and disadvantages of various donor sources. Again, haploidentical donor HLA matched haploidentical family donor is almost available. Availability is predictable. Speed of acquisition is very fast. Cell dose can be optimized, and also post transplant for various interventions, the donor is always available. So that is the advantage. And with regard to the transplant clinical issues like engraftment reasonably fast in haploidentical stem cell transplant compared to cord blood transplant, and graft failure nowadays with newer techniques is becoming less common even in haploidentical transplant, and GVHD is also low due to various GVH prophylaxis platforms. The major obstacle haploidentical transplant is higher relapse risk. So again, comparison of clinical outcomes. Again, this was published in JCO 2013. You can see with regard to the probability of survival, the best one is match-related donor transplants. But you can highlight, you can just look at the B curve, whereas the disease-free survival is best in the haploidentical transplant in this paper. So again, that is one of the logic why haplo transplants are becoming more common across various societies. So with regard to donor choices, of course, there are various set guidelines through various societies about donor selection criteria, but we tend to prefer younger patient who is preferably without any anti-HLA antibodies, and who is preferably a CMV zero status match with the patient. So this is an example of unrelated donor search report. I'll skip this. And this is important with regard to, the alloreactive in mismatch transplants. If the donor is, you can see, I'll just highlight here. If the donor is homozygous for one particular locus and the recipient is heterozygous at that particular locus, there is the reaction is toward GVHD direction. Whereas if the recipient or the patient is homozygous at HLA mismatch locus of the donor, the reaction is inclined towards more rejection. Whereas if there is complete heterozygosity in both the arms, both the locus, there is both rejection as well as GVHD risk is heightened. So again, these are various algorithms. I'll skip this. There are various set guidelines, and again, so this is summary of donor priority. We tend to choose donors without mismatched donor transplant without donor specific antibodies. Younger donor, male donor, sibling donor over parent donor, father is preferred over mother, and ABO matched over ABO mismatch. Again, Keir and all, I will come to that later. So NEMA versus NEPA, again, I'll skip this part because the time will be less. So there are various society guidelines, whereas algorithms you can study, and this is what you select the donor preference in the family when you consider haploidentical stem cell transplant. Child, mostly NEMA mismatch is first preference. Younger brother, again NEMA mismatch, second preference. Older sister, NEMA mismatch. Father is the third choice, and the fourth choice is the older patient, and the last choice is the mother. Again, Kir, there are different killer inhibitory receptors genotype, haplotype associated scores, and there is an evolving concept that the Kir mismatch have better outcomes. So these are various papers on that. So the algorithm of donor search, essentially tomorrow it is postulated that the matched sibling donor transplant, because the haplo transplant, the long-term disease-free survival is being achieved as par with matched sibling donor transplant. So more and more haplo donors are being preferred for malignant indications versus unrelated international donor transplant. So again, common misconceptions for those of the audience, the August audience who are not hematologist or bone marrow transplant. Bone marrow transplant is not a major surgery like kidney or liver transplant. It is a simple stem cell transfusion like blood transfusion, but it comes with a lot of intricacies and complications. That's why you need a dedicated bone marrow transplanter and a bone marrow transplant unit. Again, blood group matching, I emphasize, is not essential. What is important is actually gene matching, either full or half. Again, donors, many times I see a lot of donors are scared to come forward to donate the stem cells. It is not risky for the donors to donate the stem cells. It is as good as platelet apheresis with minimal risk to the donors. And most important for clinicians, bone marrow transplant is the last step with dismal outcome. That is a myth. Bone marrow transplant is the only curative therapy with very significant curative potential across vast hematological spectrum. That needs to be kept in mind. So coming to part 4, the BMT dynamics. So how we do the bone marrow transplant, the logic is, as I mentioned earlier, the bubble care. When you want to destroy the diseased bone marrow and repopulate it with the healthy bone marrow, you need to destroy with either chemo or radiotherapy, and patient ends up with such profound cytopenias, and caring for this patient during the cytopenic phase is crucial, and that is done in the dedicated HEPA filtered unit that is called as bone marrow transplant unit. So again, bone marrow transplant unit, we have come a long way, just like what we have come in field of air travel, as I mentioned, as I showed here. So compared to bubble care of 70s and 80s, again with Dr. Donald Thomas at Fred Hutch Cancer Center, these are the modern bone marrow transplant units where everything is taken care so meticulously with so much aseptic and neutropenic precautions to safeguard these patients from various infections. So there are three parts in the bone marrow transplant: the conditioning chemotherapy, basically, which the rationale is to eliminate the diseased marrow, and also it is immunosuppressive to prevent graft rejection, and it is usually administered over a period of 6 to 7 days. So simultaneously, the donor in allogenic stem cell transplant gets GCSF to mobilize the stem cells from the bone marrow to the blood. So the goal of conditioning regimen is cytoreduction as well as immunosuppression, and this is depending upon the intensity of the conditioning. It can be either myeloablative, where it leads to profound pancytopenia within 1 to 3 weeks, and this pancytopenia is irreversible without stem cell rescue. Whereas in reduced intensity conditioning, it leads to profound significant cytopenia, does require stem cell report, but there is more than 30% reduction in the doses of either chemotherapy or radiation used in the conditioning. Whereas my non-myeloablative is minimally myelosuppressive. So these are the various milestones, evolution of various conditioning chemotherapy drugs. 1960s radiation-based conditioning, then 1970s cyclophosphamide, ATG methotrexate, 1980s busulfan. Again, cyclosporine was discovered during 80s as a GVS prophylaxis. Subsequently, 1990 thiotepa, and 2000 fludarabine and triosulfan. And nowadays, the future is going to be targeted precision medicine based conditioning. So again, a conditioning regimen intensity depends on the disease for which it is used. There are diseases where you need more myelosuppression, mostly leukemias, whereas conditions with unrelated donor transplants, you need more profound immunosuppression. So the dose intensity varies, and as you increase the myeloablative potential of the conditioning, the treatment related mortality at day 100 keeps on increasing from 2% to more than 10% as you intensify the conditioning chemotherapy drugs. So again, as shown in this graph, the transplant related mortality, the moment you start increasing the conditioning chemotherapy intensity above the age of 40 years, you can see the curves separating apart, and the curves are widely separated in people above the age of 60 years. So the mortality drastically goes high in elderly patients with regard to myeloablative condition. And that's where this reduced intensity conditioning, where you tend to achieve mixed donor chimerism for the correction of immunodeficiency, genetic autoimmune disorders. And long run, because of the graft versus host disease, the patient achieves full donor chimerism, thereby achieving the cure of various blood cancers, most notably. So again, there are various diseases who have a different graft versus tumor effect. The effect is not uniform across all the blood cancers. CML has the highest GVL effect, where 80% molecular remission can be achieved with stem cell transplant. Again, Hodgkin's lymphoma is another malignancy, and as you go down, AML, another intermediate GVL effect with cure in 20%, responses in 15 to 30%, and the least is in ALL, well, remission 0 to 20%, and overall survival less than 50% if the patient has active disease at the time of transplant. Now, conditioning regimens, there is a paradigm change in our understanding. You can see the old concept, the marrow ablation is mandatory for engraftment. Conditioning regimen is the mainstay of tumor eradication. That has been replaced by the newer concept where host immunosuppression and survival advantage of donor hematopoietic stem cells by exploiting the GVL effect is the key for success of transplant. And traditional conditioning is prohibitive because of its toxicity in the older patients and patients with comorbidities. And this is based on this, you can see we are reverting to more immunosuppressive, reduced toxicity conditioning nowadays. And you can see, so TBI based versus targeted IV busulfan based conditioning, you can see the long-term survival, the curves clearly separates apart, showing that at 2 years the busulfan IV has 56% survival compared to 48% survival in the TBI based myeloablative conditioning. And that's why we are getting more and more wiser. So just to highlight another paper, the impact of conditioning, says a BMT CTN 0901. So this trial was halted permanently in myeloablative versus reduced intensity conditioning for AML, because myeloablative conditioning there was clear survival advantage, and that's known for many years. And where younger fitter patients, our always preference is myeloablative conditioning. So the optimal conditioning regimen is which will allow consistent engraftment and which will be minimally toxic, which will allow the cancer elimination with reduced toxicity without compromising the transplant efficacy. So again, the reduced toxicity concept came in 2010s. With the advent of, you can see the various alkylator agents, they have various organ toxicities, most notably liver toxicity, sinusoidal obstruction syndrome, pneumonitis, hemorrhagic cystitis, and convulsion. But triosulfan has relatively better toxicity profile and is a promising agent. You can see VOD incidence 0 to 5% compared to 10 to 25% in busulfan patients. Again, GVHD risk is less, and NR non-relapse mortality at 1 year is almost much lower compared to IV busulfan, and that has led to better overall survival on long run. So the stem cell transplant conditioning consideration, the time sequence is important. For example, if you are adding the nucleoside analogs and alkylators, the fludarabine should be given first, followed by the alkylators, busulfan, triosulfan within 2 to 3 hours. Again, timing of ATG is also important. For alternative donor transplants, consider either TBI or radiomimetic T lymphocytotoxic agents like thiotepa, because the rejection risk is high. Early ATG to eliminate mature host T cells and thereby decreasing the risk of graft rejection. Again, post-transplant novel salvage regimens like inotuzumab in ALL. So here, because the inotuzumab, these kind of novel drugs are inherently hepatotoxic, you should avoid dual alkylators, otherwise the incidence of hepatic toxicity can be quite high. So again, for immunocompetent hyperreactive marrow like seen in thalassemia, sickle cell disease, if these patients are taken for alternative donor transplants, the rejection risk can be high. So always consider pre-transplant immunosuppression to decrease the incidence of graft rejection. Again, new in the transplant conditioning, there are novel targeted conditioning drugs in the development, and which hold the promise of improving the outcomes of transplant conditioning better. So these are many Hollywood, Bollywood movies on transplant, and one of them highly recommended, which emphasizes the role of transplant conditioning toxicity busulfan associated pulmonary fibrosis in this young girl with SCID who underwent transplant in UK in late 90s. A beautiful movie. So coming to stem cell mobilization, there are various ways we optimize stem cell mobilization, mostly in autologous transplant as well as in allogenic transplant. The commonest one is GCSF based stem cell mobilization. But when the stem cell mobilization is suboptimal with GCSF alone, you use plerixafor or chemotherapy like cyclophosphamide 5 myeloma, and for lymphoma, ICE or DHAP salvage regimen. So again, predictors of collection. So many centers, they do day 4, day 5 peripheral CD34 count, and if the count is more than 10 per microliter, it is sufficient for one transplant. And if you are planning for second transplant, the count should be at least 20 per microliter. So at our center, we don't do day 4, day 5. What we do, we start with the stem cell collection and we send the CD34 count after 100 ml collection, and that gives us an advantage to plan the amount of stem cell product to be collected, and as well as to optimize the stem cell dose, mostly in the alternative donor transplant, where mega dose of stem cells is crucial. Now, second in line, the second step of donor transplant. So at the end of this conditioning, you collect the stem cells from the donor. In autologous stem cell transplant, you already collect the stem cells, freeze it, and then start the conditioning chemo. And at the end of the conditioning chemo, you infuse the stem cells back to the patient. So again, after this, your peri-transplant period till engraftment starts, and the early complications, just a brief synopsis of early complications in peri-transplant period. So autologous transplant, sometimes you can see engraftment syndrome incidence as high as 7 to 10%, and it typically develops around 7 to 12 days post-transplant, around the time of neutrophil recovery. And the logic or the rationale for such engraftment syndrome is because of increased capillary leak, and patient presents with respiratory distress, fever, and skin rash. And on chest imaging, you can see bilateral ground glass opacities, perihilar or peribronchial consolidation, and the treatment is usually after ensuring normal neutrophil counts or improving neutrophil counts. You can start them on short course methylprednisolone, 1 to 2 milligram Q12H till for 2 to 3 days till this respiratory distress resolves. The cardiac toxicity, more so in pre-existing cardiac diseases and cardiomyopathy, as well as the drugs used before the transplant causing QTC prolongation and dyselectrolytemia, hypertension, and this can lead to various cardiac toxicity. Nowadays in haploidentical transplant arm, because of the post-transplant cyclophosphamide, the hemorrhagic pericarditis as well as myocarditis is not so uncommon. So acute renal toxicity, another common organ toxicity. Most common causes are either acute tubular necrosis, drugs like CNI, aminoglycoside antibiotics, or antifungals like amphotericin, and also with hepatorenal syndrome of hepatic VOD or sinusoidal obstruction syndrome. The less common one are thrombotic microangiopathies, tumor lysis syndrome when the transplant is undertaken with active disease, or hemolysis due to ABO incompatibility. And most of the times the toxicity, the renal toxicity is multifactorial. Now, hepatic sinusoidal obstruction syndrome, it is defined by a triad of hepatomegaly with right upper quadrant pain, right hypochondriac pain, third spacing fluid retention like ascites, pleuropericardial effusion, and jaundice, bilirubin more than 2 with cholestatic picture. So the features like there is always a weight gain, increased platelet transfusion requirements, and there is active coagulopathy. And the incidence varies from 10 to 50% depending upon the various criteria. And in these patients with moderate to severe hepatic sinusoidal obstruction syndrome, the fatality can be very high. So the preventive measures for prevention of hepatic sinusoidal obstruction syndrome in high-risk patients is to use low-dose heparin, ursodeoxycholic acid, and very rarely difibrotide. Again, treatment relies on difibrotide, but since it is unavailable in India, many times we treat these patients, we try to treat these patients with high-dose pulse steroids. Neurological complications, common issues, infections, chemotherapy toxicity like fludarabine and CNI toxicity, and various drug toxicities, mostly the GVHD drug like CNI, sirolimus, and methotrexate, mostly the renal dysfunction, hypertension, neuro side effects for sirolimus, myelosuppression, and hypertriglyceridemia, hypercholesterolemia. And for mycophenolate, GI symptoms are common. Again, this is one case of posterior reversible encephalopathy due to CNI sirolimus. And this is the typical picture. So manage with the withdrawal of the drug and supportive care. Now then after this comes the post engraftment phase, where the community practitioners need to be aware of three important complications in this period. So periodic follow-up and monitor for opportunistic infections, because post transplant, even though the cells comes down to normal in a span of 3 to 4 weeks, but immune recovery, the immune reconstitution takes about 6 months to 12 months. So T cells, T lymphocytes and B lymphocytes uh, uh, take longer time. So you need to monitor these patients for various weird opportunistic infections. GVHD, graft versus host disease, just like the graft versus tumor effect, the graft donor stem cells can also, the donor lymphocytes can also attack the host, causing graft versus host disease, which can be either acute or chronic. And then the third one, in the acute setting, three organs, vital organs commonly involve skin, gut, and liver. Whereas in the chronic setting, it mimics various sclerosing autoimmune conditions like scleroderma and so on and so forth. So organ dysfunctions either because of chemotherapy or post-transplant. And in malignant indications, there is always a threat of disease relapse. So just brief about GVHD. Why does GVHD occurs? Because of the incompatible or non-tolerant T cells from the donor. There is the HLA disparities more, the age, the sex disparities there, and particularly with peripheral blood stem cell, because of the higher T cell dose, there is higher incidence of GVHD. So the pathobiology essentially evolves around alloreactive T cells, donor T cells attacking the host tissues, and after this recognizing the HLA disparity. Of course, the GVHD, particularly the chronic GVHD, has a mild beneficial effect in terms of decreased relapse, but mild manageable GVHD is actually good for malignant indications. But if GVHD is severe, it can itself be a life-threatening condition. And why GVHD focus is important? Because the incidence with the increasing number of alternate donor transplants can be higher. And nowadays, the incidence of chronic GVHD is getting lesser and lesser. And you can see last 10 years or so, the incidence of chronic GVHD is less than, there has been decrease in the incidence more than 15 to 20%. And this is because of various novel drugs and novel conditioning as well as post-transplant management strategies. So one of the drugs, ATG, anti-thymocyte globulin, acting by T lymphocyte depletion, and you can see the advantages of ATG in the conditioning. It facilitates engraftment, decreased GVHD incidence, and with a little higher incidence of infection, which can be managed. So acute and chronic GVHD definitions, there are set criteria, and this is the chart. I'm sorry for this busy slide, but just depicting the management of GVHD. The mainstay first line drug remains steroids, and for those steroid dependent or steroid refractory, you try other immunosuppressants or novel drugs like ruxolitinib. So these are various GVHD prophylaxis strategies, most notably CNI plus anti-metabolite methotrexate commonly used, but nowadays post-transplant cyclophosphamide, not only in the haplotransplant setting, but even in the match sibling, match unrelated setting, is being extensively used. And the ATG significantly decreases the incidence of chronic GVHD, and this is by these three landmark markers. You can see the incidence in the ATG arm is more than 3 times less compared to non-ATG arm, which is represented by the red bars. Again, timing of ATG is important, and these are various EBMT recommendations for GVH prophylaxis. So I'll skip that. So GVHD criteria, grading system, and various GVHD management strategies. So nowadays we have better biomarkers of GVHD development, GVHD severity, and these can be helpful in devising the better GVHD therapy strategies. And one important thing with regard to GVHD, about only 40% are steroid responsive, and of these only 30% remain maintain steroid response. So there is unmet need in patients with moderate to severe GVHD, and there are various newer approvals, like one of them in steroid refractory GVHD happened in 2019 is ruxolitinib, and with the rampant use of ruxolitinib, the GVHD management has become little better refined. Whereas in the chronic GVHD, again, two approvals, ruxolitinib as well as belumosudil and ibrutinib. So these are the, how do we choose the GVHD therapy? These are various guidelines. So you can see with simple intervention like ATG, the incidence of chronic GVHD overall decreased from 52.5% to 27.9% overall, whereas extensive 23.2% versus 8.5% in the ATG arm. This is important. This is my first allogenic stem cell transplant for aplastic anemia. I did 10 years back. Unfortunately, you can see this gentleman has been cured of his devastating disease, but ended up with such debilitating contractures and extensive fibrosis. You can see on the chest, there are contractures in the hand, and the quality of life is extremely poor. So you tend to think, is this kind of a curse you have imposed on such patients? So fortunately, such sclerosing chronic GVHD, novel interventions like belumosudil holds promise of at least halting the progress and reversing the fibrosis in certain circumstances. Now, just quick about post-transplant infections. So these happen in three phases: the pre-engraftment, during the BMT stay, post-engraftment up to 2 to 3 months, and late phase more than 3 months. This is again, as I mentioned, the rationale because of delayed immune reconstitution, and these are the various risk factors, and based on the various phases, the incidence of various bacterial, fungal, and viral infections vary. So again, the same cartoon showing various pathogens, bacterial, fungal, viral, at various timeline points. So again, mostly these infections, just a few examples in our practice, like typical gram appearance of streptococcus pneumonia in sputum, that is because of functional asplenia, as well as delayed immune reconstitution. Again, legionella pneumonia common, where the stored water, the source is stored water or community acquired infections. Again, tuberculosis mostly in patients who are on profound immunosuppression. For GVHD, most notably ruxolitinib, the incidence can be as high, and this is assist fast rods in the sputum, as you can see here. Tuberculosis, esophageal candidiasis, because of the, again, whenever the patient is on profound immunosuppression, including steroids, the incidence of these fungal and viral as well as bacterial infections go high. Another example of Aspergillus fumigatus presenting as a pulmonary nodule. Again, reverse halocine and halocine on a CT imaging, and again, another case of cerebral aspergillosis, histoplasmosis with a miliary pattern, histoplasma capsulatum. Again, you can see under microscope these bugs, fusariosis, when the patient was extensively on voriconazole for probable pulmonary aspergillosis, and you can see skin lesions as well as lung lesions. Pulmonary cryptococcosis is one of my haploid identical stem cell transplant who developed post-transplant pulmonary and CNS cryptococcosis. Again, the diagnosis was established by this India ink preparation. Strongly positive India ink smear, and you can see the cryptococcus causing large ulcer on the arm. Skin lesions of the cryptococcus. Again, mycosis, you can see the incidence can be high and mortality can be as high as 50 to 70%. And because of this extensive mortality and higher risk of these patients, there are rationale for antifungal prophylaxis whenever the patient, during the pre-engraftment as well as the patient is on GVH directed therapy. Again, pneumocystitis pneumonia, recent patient presenting with pneumocystis pneumonia post match sibling transplant. This is how PCP pneumonia looks on CT scan, and this is how on a lung biopsy the organism can be separated. And because the incidence high, there is a rationale for Septron or bacterium DS prophylaxis in this subset. Again, CMV common in alternative donor transplants, so there are monitoring and preemptive therapy guidelines. So you keep on monitoring for at least till day 100 once a week, CMV PCR, qPCR in haploidentical transplant and unrelated donor transplant. And as soon as the viral copy starts going up, you start them on ganciclovir or valganciclovir as a preemptive therapy, because once the viral reactivation is common, 70 to 80%, but viral the end organ infections like pneumonitis, retinitis, encephalitis, hepatitis, the mortality can be as high as 60 to 70%. Again, a patient of AML translocation 6-9. She's now 6 years post-transplant, but immediate peri-transplant, she has CMV pneumonitis, respiratory failure. She was on a ventilator for 12 days. But thankfully, because of the aggressive antiviral therapy along with IVIG and other supportive care, she recovered. But the case fatality rate can be as high as 85%. Again, the CT picture of CMV pneumonitis, and this is the lung biopsy depicting the CMV cytomegalovirus in the lung tissue. Microabscess is caused by CMV in the liver and CMV colitis, CMV retinitis. So because of this, these lethal infections carrying higher mortality, morbidity, there are guidelines established for the prevention as well as preemptive therapy of these infections. Again, in the winter and rainy season, respiratory viral pathogens not so uncommon, RSV, pneumonia. So these respiratory viral infections are common, and that's why you tend to care barrier, nursing even at home, and any at the slightest of the suspicion, extensive workup and antiviral therapy is mandatory. So again, principal causes of interstitial pneumonia, commonest is CMV and second commonest is PCP, and rare are the respiratory viruses. So again, herpes labialis presenting with this lip infection, intraoral extensive mucosal infection, herpes simplex, esophagitis. Because of these higher incidence and morbidity associated with it, you tend to use the valacyclovir or acyclovir prophylaxis at least for 2 years post transplant. At least 1 year post-transplant till immune reconstitution happens. Again, ABV associated lymphoproliferative disease, and the same patients get lesions and MRI lesions. So this is another patient. Unfortunately, we lost PTCL undergoing haploid identical stem cell transplant, and she engrafted, but post-transplant she has profuse diarrhea in the stool. This was the picture we have. So this was a strongyloid superinfection causing the fatality in that case. So despite these infections, caring for these patients as a team is important, and this is one of the patients who underwent mass sibling donor transplant for aplastic anemia about 7 years back, and surprisingly, and to my surprise, she was recently seen with a cute 3-year daughter in her lap. So patients do conceive after non-myeloablative immunosuppressive conditioning also. So gearing further just about chimerism analysis, again, these are various techniques. So there are set guidelines how to monitor mixed chimerism and how to intervene. So when the patient is on immunosuppression showing mixed chimerism at various time points, you tend to decrease the immunosuppression or stop immunosuppression. And despite that, if still the patient continues to have mixed chimerism, you revert to donor lymphocyte infusion to re-establish the donor chimerism. Switching gears further, the evolution of haploid identical stem cell transplant, again, groundbreaking work by Reisner, early 80s. So allogenic transplantation using stem cell fractionated by lectin, that was his research thesis, PhD thesis in Israel, and that has paved the way for early T-deplete haploid identical transplant, and the work most notably by Reisner and his group at MSKCC, Richard O'Reilly, and other people. So there are many papers, and this was the first successful T-deplete haploid identical stem cell transplant in a child with SCID in 1980s. Again, post radiation nuclear accident, the work was more took a new speed, and a lot of this. So the cumulative incidence of survival in SCID, particularly the immunodeficiency disorder SCID, you can see the survival in half mass transplant is as good as full mass transplant, provided the child is taken for transplant earlier. Again, Chernobyl nuclear accident, and this led to various haploid identical stem cell transplant as an emergent measure across these subgroups, and with significant improvements. And another breakthrough came when Stefano Milteni in late 90s developed this 1.5 Tesla magnetic separator in the clinic max machine, leading to separation. So essentially this was developed as a purging technique for pediatric solid tumors, but they found that the CD34 stem cell can be nicely separated, and this led to evolution of T deplete transplant. So we have come up a long way in the field of T deplete haploidentical stem cell transplant. Initial CD34 selection, subsequently TCR alpha beta CD19 depletion. So essentially this Clinimax machine, what it does is it the microbeads this lectin and biotin antibodies, they separate in this magnetic field the good T cells as along with the stem cells, like good T cells like gamma delta T cells, NK cells, dendritic cells, along with CD34 T cells, and separate out TCR alpha beta, which are the major alloreactive donor T lymphocytes. And that's how the graft manipulation, graft engineering can lead to better outcomes. So the outcomes are very, very rewarding. So this was the 2014 paper by Alice Bertina. So removal of these TCR alpha beta and CD19 B cells is an effective strategy for haploidentical stem cell transplant, with results very, very promising. So NK cells, again, being separated in along with the stem cell product, have a multitude of function, not only antiviral but anti-tumoral immunity, and also they have protective effect in GVHD. So all these good cells are separated out and are transfused in along with the CD34 positive stem cells, leading to better outcomes. So this, based on their promising early results, this was the editorial in Blood 2014. Haplo is the new block and another platform for adaptive immunotherapy with more better T cell reconstitution post haploidentical stem cell transplant. So again, various cartoons depicting the same. So the challenges is transplant is the unmet needs, the toxicities, infections associated with delayed immune reconstitution, GVHD, and disease recurrence. And all of this can be, there are efforts to improvise immune reconstitution, and it has been found across various studies. Those patients with better immune reconstitution at various time points, their outcomes are more than 20-30% better than those with delayed immune reconstitution. So you can see various paper overall survival benefit ranging between 20 to 25%. So based on that, there is a newer, adaptive immunity by way of T cell reconstitution, because it has been found that the memory T cells, which are the major detrimental T cells, alloreactive T cells, so they have skewed repertoire, so and they have limited response to infections, and they are removed by this new T deplete platform CD45 RA T cells, and you add back CD45 RO isoforms. So CD45 RA are naive T cells. So and they are, and whereas CD45 RO, these are memory T cells who are less alloreactive, they maintain viral specific activity and they mediate graft versus leukemia effect. So amongst the T lymphocyte subset, CD45 RA negative, RO positive T cells are better, and you add back those RO positive T cells for better outcomes. So again, the outcomes are much better. You can see in these graphs, CD45 RA depleted, the black bars, black curves have the highest survival long run. The number of alternative donor transplants are on high rise. Mostly the haploidentical stem cell transplant that was in North America, this was in Europe, and same is true for even in India. The number of haploidentical transplants and the alternative donor transplants are on high rise. Even with that, less than 5% of the patients who actually need bone marrow transplant in India are getting transplanted. And then this is limited by multitude of factors. For example, there are more than 10,000 children who are born with thalassemia every year. And the number of transplants undertaken for curing such thalassemia major children is less than 500 even today. So we need to accept these challenges and we need to find solutions for our own subset of patients. So I'll just quickly run over another case, interesting case. This is again a boy with severe aplastic anemia with osteomyelitis of the pelvic bones and hepatitis, resolved with the supportive care, antibiotics, and then he's taken for first half match transplant with father as a donor. Unfortunately, he rejects the father stem cell graft, second half match transplant with mother as a donor. Um, Develops HLH post transplant, and managed with novel drugs like ruxolitinib upfront for HLH, because the fear of losing the graft with more myelosuppressive etoposide was not acceptable in this case. And this child continues to do well. So this is almost 2 years post transplant. So number of transplants, you can see T deplete, T replete, PTCY based haploid identical transplants are on the rise. So we need to acquaint ourselves to these changing scenarios, and how to care for these patients. So the logic of haploid identical stem cell transplant, PTCY, and so the numbers are shooting across the globe. And one of the advantages of this PTCY based reduced intensity, reduced toxicity conditioning, it is applicable to older patients. So just an example, this 65-year refractory AML who underwent PTCY based haploid identical transplant with reduced intensity, reduced toxicity conditioning. And even though he has a peri-transplant turbulent course, he's 1.5 years post-transplant, doing well with manageable chronic GVHD. These kind of elderly patients with such refractory AML, getting such a longer disease-free survival were unheard of. But thanks to the novel techniques, technologies, and novel improvements in the supportive care, these are becoming a reality. So you can see the trends in survival across transplants. Decade by decade, there is much refined, more improvement in the survival, both in malignant, non-malignant conditions, and also in the autologous transplant scenario. And the death, again, the causes of death still remains the disease relapse as well as the infections and GVHD. So just my last part, so the future of transplant, I will skip. So as I mentioned you earlier, the T-deplete haploidentical stem cell transplant has been extensively used as a platform for further immunotherapy, improving the outcome of such transplants. So there are many various ways. After the first experiment by Leo Luznik and group in 2008, they taught us how to tolerize the donor T cells by PTCY, and based on that platform, there are various novel interventions like using tolerizing donor T cells beyond PTCY by way of adding donor NK CAR T cells, or not only that, in the pediatric multi-system genetic disorders, the organ transplant in coordination with bone marrow transplant without the necessity of lifelong immunosuppression. One of the example is Schenke's immuno-osteodysplasia. So these are the realities and survivals which for the patients who didn't had any hope of survival beyond 3-6 months, and this is being possible with various not only the transplant arm but novel immunotherapies and cellular therapies being incorporated in the transplant arm. Again, the CD3 CAR T cells, CAR NK cells as a post-transplant strategy to decrease the disease relapse rate. Again, anti-TCR alpha beta antibody to decrease the incidence of GVHD as well as to decrease the incidence of relapse in this haplotransplant arm. Another a nice movie elaborating the role of beautiful narration of CAR T cell therapy, highly recommended, A Family Man. So again, anti-ATG antibody, imlifidase, another novel useful immunotherapy intervention to decrease the incidence of opportunistic infections post rapid ATG. So there are various immunotherapy, cellular therapy, post-transplant interventions which are under experiments, but they hold the promise of improving the cure rate much significantly better. So again, these are our post-transplant adaptive immunotherapy platforms in haploidentical setting, and this whatever is happening in this picture, what is precision medicine? You can see this is an example of precision. Race car the four wheels being changed in a span of just 1.8 seconds. And that kind of precision medicine is happening in the field of hematology and hematopoietic stem cell transplant. Again, autologous transplants for uncontrolled, suboptimally managed autoimmune conditions. So the COVID vaccine has highlighted, normal viral vaccine, which takes 10 to 15 years to develop. The development was, even in a country like India, it was the effective, efficient vaccine was developed in a span of 9 months. So that is the impact of science and technology nowadays. And the future of transplant seems to be exciting. So we definitely need to change our approach, attitude, and acquaint ourselves to these novel interventions, technologies, and scientific interventions to offer the best possible chance of cure and survival across the vast spectrum. So with that, I will conclude my talk.